We had a lot of folks sign up for this, so very excited. So today's webinar is exploring long COVID treatments, go-to, promising, and experimental. It's going to last about 75 minutes. We'll start with a conversation with our panelists for about the first hour, and then we'll have Q&A from the audience for the last 15 minutes. So those in the audience, please use the Q&A button to submit questions. We'll be going through and trying to answer as many of them as possible. And if you have a question that's directed to a particular panelist, please put that in your question so we know who to direct the question to. All right, so I'll be moderating. My name's Jennifer Curtin. I'm a physician. I'm the co-founder and chief medical officer at Rhythm. And I will be doing the intros of our amazing panelists today. So I'm going to start out with Dr. David Putrino. He's the professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine in Mount Sinai, New York City. And he's the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illness. David trained as a physiotherapist in Australia before completing a PhD in neuroscience. Since the beginning of the COVID-19 pandemic in 2020, David has been recognized globally as a leading expert in the assessment, treatment, and underlying pathophysiology of long COVID. His team has managed the care of over 3,000 people with long COVID and published multiple peer-reviewed scientific papers on the topic. In 2019, he was named Global Australian of the Year for his contributions to healthcare. Welcome, David. All right, and now we have Dr. Leo Galland. He's a physician at Leo Galland MD in New York City, international best-selling author and recipient of the Linus Pauling Award from the Institute of Functional Medicine. Leo has been diagnosing and treating long COVID patients since 2021 and brings a functional medicine approach to long COVID management with areas of focus on the gut microbiome, mitochondrial health, and tick-borne diseases. And last but not least, Dr. Stuart Malcolm. He's the physician and medical director at Rhythm Clinic. Stuart has treated hundreds of long COVID patients since March of 2020 and brings a wealth of experience, knowledge, and a true passion for care to the table. He has particular interests in endothelial and mitochondrial dysfunction, iron dysregulation, EBV reactivation, and SARS-CoV-2 viral persistence in this patient group. All right, so we've done our intros. We've got an amazing panel here. Thank you guys for coming out today and spending this time with us. This is really, I think, a helpful topic for just so many people out there, so thank you. And we are recording this, and we will be posting the recording on our YouTube channel. And, you know, Leo and David, if you guys want to post it, repost it as well, you absolutely can. So I'm just going to jump right into topic number one, and we're just going to go through each person. What would you consider to be your go-to first-line treatments for long COVID? You can say more than one. And we'll start by just saying, are there any that you consider that kind of work across symptom presentations? And I think probably let's jump in. David, you want to start us off?
Yeah, absolutely. You know, and I'm going to start off really, really basic. I think that probably the most useful conversations that we can have starting off across the board, no matter who is coming in to see us. We know from literature, probably over 90% of people with long COVID will talk about having post-exertional malaise and fatigue as part of their symptom profile. So many individuals with long COVID are highly sophisticated in their self-management, but many people are new to the world. They haven't read a lot. So conversations around pacing, conversations around common triggers of worsening symptoms, such as, for instance, hot environments, loud environments, you know, things of that nature, and providing strategies beyond pacing about how to regulate body temperature and maintain good hydration and things of that nature tend to be extraordinarily helpful for the newbies who haven't figured this out, you know, for themselves along the way. Moving into hydration. So, you know, again, this is the sort of stuff, hydration with electrolyte support tends to just across the board help the biggest proportion of people that we see. And then from there, moving into mitochondrial supplementation. So I think that a lot of folks finding the right blend of mitochondrial supplementation is important and may take a little bit of tweaking, but in general, people do tend to get a boost from mitochondrial supplementation, things such as CoQ10, alpha lipoic acid, other NAC, NAD plus, working with people to identify the supplements that work for them, but with the understanding that almost everybody who is experiencing post-exertional malaise cognitive impairment has some element of mitochondrial dysfunction occurring. And regardless of if you're addressing the root cause, if you can support some of the oxidative stress that is occurring and enhance the function of mitochondria, you may give them a little bit more resilience to exertion and a little bit more function back. I'm sure there's like a million other things that we could talk about, but I'm going to pause there to give other people, opportunities.
No, that's a great, that starting with the foundation and the basics those are such key things. So thank you. I think Leo, we'll go to you next.
Sure. I mean, I definitely share David's perspective. I think self-management and self-awareness are the foundation. And anybody who's really been sick with long COVID, who has gotten well, and I've seen many people who have gone from being bedridden to being fully recovered, they've all mastered self-management. I mean, that is an essential part. Above and beyond pacing, sleep, really important. And if there's difficulty sleeping, there are a number of different supplements. I prefer to start with natural products before going into drugs. I don't know if you want me to mention those now, but the other part of self-awareness that I think is important, aside from how do you respond to what kinds of stressors and exercise, and so you can try to determine how you set your limits, with the idea that this is not the goal. Setting limits is not the goal. It's the means to getting to a goal, which is where you don't have to worry about setting limits. I mean, that is the process that I try to encourage in people. But how do you respond to food and to eating? Do you do better if you don't eat? Or do you do worse if you don't eat in terms of your energy and cognitive function? Are there specific foods that seem to be problematic for you? Do you have GI symptoms or other symptoms that are impacted by food? Diet, there's a significant percentage of people with long COVID who are very sensitive to food, and that leads to certain treatments. So that's what I would start with. I agree that CoQ10 and antioxidants like alpha lipoic acid and NAC are often helpful. I created a document that's on my website, no charge for any of this, and a couple of videos in which I outline a specific approach with supplementation. And I'm not going to go into the details of that now. I will say that I find curcumin and resveratrol to be very useful supplements for multiple beneficial functions that they have in the body in regulating inflammation and brain function.
Awesome. Thank you so much, Leo. So kind of just a small recap. So we've got pacing has come out with both, like learning how do you pace your activities? What are the limits you have to set? And part of that is also identifying your triggers. What are the things that set off your symptoms so that you can kind of give yourself that ability to move forward and expand those limits as you go forward. And then mitochondrial support antioxidants have come up for both of you. And so now I'll segue into, I think, Stuart, if you want to go next, knowing we've kind of got like a pretty good consensus here. Leo, you also did very much emphasize sleep as being very critical as well, and how to optimize that.
I think the few things I want to say. one, there's going to be some people in the audience who are saying, I know how to pace, I know to do that. Like sometimes I have to remind myself as a physician in this space of like making sure we're hitting the basics, and that's just like really important to hear. It's hard when you're talking about a treatment not to talk about the fundamental causes of something. And so I think one thing would be right away is this long COVID or not? And no one even knows what even that statement means, because the current definition from the WHO and the CDC basically says you have long COVID if you had COVID, and then you're having adverse reactions from it. The current data we have, lots of EBV, reactivation. Is that a part of long COVID? Is that long COVID plus? We're not sure. How much of this is mold toxicity? From Timothy Hendrick's lab at UCSF, a third of long COVID patients have mold evidence in their blood. How much is this is this Bartonella babesia? And so that's a really hard thing, because we've kind of started off talking about the mitochondria, and there's good papers that I think the initial one came out of Canada of how the virus attacks the mitochondria. For everyone in the room, the mitochondria is makes 95% of ATP. Not only is it important for energy, but ATP is important to get everything done. So I agree kind of with everyone in the statement. I'm just going to make a few statements, which would be oxaloacetate. Not sure if that was mentioned. There's a randomized control trial published at the Bateman Horne Center back in November. That is a great option. It fits right into the Krebs cycle. I've had some good benefit in that. There's another paper that came out about NAD+. I know it was mentioned already. Great option. Logistically, I have no kind of vested interest in Ageless RX, but that's like a website you can get it either intranasally or patch-wise or injection. Those are things that just kind of work. Like people are like, oh, wow, I got a bit of energy. And that's super helpful for us clinicians when you're just too tired to go get testing done or, try other things. So I definitely add that. I want to mention a few other things. Nattokinase, I've given a lot of blood thinners to people. Nattokinase has been helpful. It's something to go to. I do want to mention some of the antivirals and of course MCAS, but there are quite a few, but maybe we'll take a pause and we can kind of direct into those specific ones.
Yeah, so I think, so that was kind of the loop through of what do we do just in general across long COVID patients? Like what have you kind of found helpful just in general, no matter how the person presents, what their symptom profile is, et cetera. So now let's go back through and let's kind of target, and I know kind of everyone talked about a lot of like pacing and things like that. So let's start with the folks who have post-exertional malaise or who meet the full criteria for ME/CFS. So we can loop back through, and I think maybe we just kind of go back through the same order. So David, if you want to start.
Sure. Actually, and not to be wildly redundant here, but I am, now that we move away from long COVID and we move into ME/CFS, I'm going to echo Stuart's sentiments here, because I do think that when we're working with ME/CFS, our clinic and the physicians working at our clinic utilize the Canadian consensus criteria for diagnosis, which are fairly rigorous, diagnostic criteria for ME/CFS, but still very broad. They're symptom-based diagnostic criteria, which means that people's ME/CFS symptoms could have been driven by an infection. They could have been driven by exposure to something. They could have been driven by a physical trauma that occurred that has kicked the body into some sort of, immune dysregulation that leads to symptoms that are emerging. And one thing that I will say that is not a statement that is intended to be without hope, but it is a statement that, we've certainly found to be true, is that the longer people have had symptoms for, the more complexity there is to their symptom presentation. So when we're dealing with folks with pre-2020 ME/CFS diagnoses, we often find that, there's going to be a lower percentage of everything, like everybody benefits a little bit from X or everybody benefits a little bit from Y. Certainly, some of the things that we're interested in that I think a lot of people have commented on has been not on this time, but a lot of people have published on and spoken about. I think, low dose naltrexone is one of those things that a lot of people get a little boost, has been the experience of our clinic when we're talking about pre-2020 ME/CFS. It's something that needs to be done extraordinarily judiciously because so many people have medication sensitivities, and so many people, can't tolerate jumping onto a high dose of low-dose naltrexone immediately. So it needs to be very judiciously, applied. But not just us, but a lot of other clinics that we've spoken to have kind of said, listen, it's not a cure, and it's not something that is, gonna change people's lives. But as we all know in this space, if you're getting 10 or 20% more out of your symptoms, that's a big change in quality of life a lot of the time. And that's kind of what we're talking about there. We do see the occasional, larger effect, but usually it's a very small, effect. Beyond that, there's again, it needs to be finding the right thing for the underlying cause has kind of been our experience. So you'll hear miracle responses to Valtrex, and to Stuart's point, that was probably EBV or other herpes viruses are in play in that person's symptom profile. You'll also, hear about folks who are dealing with cervicocranial instability and the role of rehabilitation and or even surgical management in some cases to benefit them when they've been quite sick. And then, of course, the other thing that I think is worth mentioning here, even though I don't want to merge topics, but antihistamines and the role of supplemental O2 can really give a lot of patients with ME/CFS a boost.
I'm curious for the supplemental O2. So what sort of, is it like, do you do just like 2 liters a minute through like nasal cannula? How long do you have them use it for per day?
So, with the supplemental O2, where there are protocols out there, to your point, some people talk about nasal cannula, et cetera. We've actually just started, and again, so we should probably go even, we could sort of talk about this in experimental, but we've started working with, air compressors and full rebreather masks in clinical trial. And the immediate results have been really quite promising in a significant percentage of people who have been trying it out. So where it's been something that's been out there, especially in the MCAS world, just because of the ability for mast cell activation syndrome to cause issues with diffusion and oxygenation of tissue. And what we're interested in is, okay, well, what are some efficient delivery methods? What are some things that people can safely do at home? What are some things that might be somewhat safer than carrying around oxygen tanks everywhere you go, from a practical standpoint, or just, not even safer, but just like less exertional. And these are some of the things that we're looking into.
There are home oxygen concentrators that people can
yes. Yeah. That's our direction, Leo. So right there with you.
Yeah, they can be pretty expensive though if insurance doesn't cover them. So yeah. No, thank you for that. That's wonderful. And I just want to interject as well. We are talking about specific therapies and how we're using them in our various clinics. But this is not medical advice. So always consult if you're listening in the audience or if you're listening on YouTube. Always consult with your care provider to see if these things would be good for you in your specific case. Every single person is unique. So this is for educational purposes and meant to just provide ideas that you can discuss with your providers. All right. So let's jump to Leo.
So in the context of what we're talking about and kind of the differential diagnosis, when I see a patient with long COVID, I always start by taking a complete life history. And they may want to talk about what's happening now. And I find myself often saying, well, we're not up to that part of the story yet. Let's go back, because I want to know, who was this person that this happened to? Was this someone who had had allergies or asthma, chronic illness, depression, trauma, head injury? A very important thing to inquire about. I mean, head trauma has many effects in the brain that are similar to acute infection in the brain, both biochemically and reactivating latent viruses. So what I attempt to do is to go through a history of that person's health from birth, to the extent they can remember it, up until they got COVID, and then look at the factors, what changed. Now, I see a lot of people who are really, really healthy. They were athletic, they ate well, they were lean, they were very productive, and then COVID just totally, just changed their lives. But I see a lot of other people who had different illnesses that were occurring, some chronic, some subacute, and that's important. And the question, one of the questions I want to answer is, to what extent is it likely that what's happening in this person is that having COVID exacerbated an underlying condition that was kind of lying there, pretty inactive, or only bothering them a little bit? And that happens pretty frequently. So the treatment is really going to depend on the assessment of what are the factors that are acting as triggers for this set of events. The other way, and this is something I kind of developed, 40 years ago, was thinking about chronic illness in terms of triggers and mediators. That is, there are triggers, and the triggers activate mediators. And in the case of long COVID, the mediators include impaired circulation because of inflammation of blood vessels and microclots, mitochondrial damage, and there are many mechanisms of that. Sometimes there are autoantibodies, T cell impairment of immune function, which is the main reason that you get reactivation of latent viruses, or other infections, which might include a tick-borne illness like Lyme disease. So I try to think that through, and there's no way I can quickly encapsulate it for someone, a health professional or a patient, to, oh, this is how you do it. Talking about the CFS, ME, and the post-exertional malaise component. Without a doubt, in my experience, PEM is the most challenging aspect of long COVID, because we don't really understand it as well. Why is it that if somebody who's kind of learned to manage their level of activity overdoes it a little bit, either physically or cognitively, there maybe 2 days later they crash for 3 months? I mean, that's an extreme example. No one has figured out, like, what's the mechanism there. It's one thing that you can understand why somebody might be fatigued, but this PEM component. So anyway, so I have a theory that I put together, and I've started to work with patients on it. I think it has merit. I think it's actionable. We'll see how far it gets us. And I think it's largely due to a combination of impaired circulation and mitochondrial dysfunction. And it's the model that I use, and in the article on my website, I did post the preliminary work in progress that I created around this. The model that I've used is something called ischemia-reperfusion. With this, ischemia means lack of blood flow, and you get a lack of oxygen in tissue. With a heart attack or most strokes, that's ischemia. But the major damage doesn't occur from the ischemia. It occurs after the ischemia when blood flow returns. That's the reperfusion. There's a lot of oxidative stress. And there have been a number of studies that looked at ischemia-reperfusion in animals and in humans with strokes and with heart attacks. And so I've tried to apply that research to the problem of PEM. And PEM really is a very bad name. What happens to people is way more than malaise. I mean, it can be agony. Post-exertional agony is a more fitting name for most of the patients I've seen. And okay, so one of the things that happens if you have relative ischemia and therefore relatively low oxygen in tissues, when those tissues start to work, and this could be the brain, it could be in the muscles, the Krebs cycle starts to work in reverse. This really blew me away when I saw this. The enzymes, ordinarily the Krebs cycle runs in a particular direction, and the main thing it does is not to produce energy, actually. The main thing it does is to produce NADH, which is the reduced form of NAD that goes into another part of the mitochondria to allow something called the electron transport chain to produce ATP at a very high level. Well, the Krebs cycle starts running in reverse. You get a lot of oxidative stress in the mitochondria, and that creates damage. The second thing that happens is you start to get a buildup of lactic acid because you don't quite have enough oxygen to make the whole system run the way that it should. And lactic acid is not just a waste product. That's the way that most doctors think about it. It actually goes into mitochondria and it creates more oxidative stress, more free radical damage. That's why there's the delay. You can kind of maybe push through it, but then you really pay the price afterwards. And I think a lot of the research really supports the idea that something like that is happening. So Stuart mentioned oxaloacetate. If I'm getting too technical, just let me know, okay?
We are running a bit behind on time,
okay,
so.
all right. Okay, all right. Anyway, it's all explained in writing. Oxaloacetate can play a very important role in that whole cycle, and the timing is important. I have people use it just before exercising.
Okay, no, that's really interesting that you actually pre-dose it right before the exertion.
Right, and then there are things after exertion to try and compensate for what just happened.
Okay, and do you want to just rattle off a few of those that you just tend to use?
So the most important enzyme that runs in reverse is something called succinate dehydrogenase, or respiratory complex 2. And oxaloacetate actually inhibits it. So on the one hand, it's a fuel for the Krebs cycle, but it's a fuel that inhibits that enzyme that you do want to slow down. And all these animals, there are animal studies showing if you can slow that down, you can decrease the ischemia-reperfusion injury. Something else that inhibits that enzyme is a flavonoid called chrysin, which is found in a number of foods. So I'll use a combination of oxaloacetate and chrysin. I don't know if you've had this experience, a number of my patients have not tolerated oxaloacetate because of GI side effects. Chrysin's easier to take, but I'll have them take the two of them before activity. Recovery from activity, I've been using PQQ, pyrrolidinoline quinone. It's related to coenzyme Q10. It's found in a number of foods. It is available as a supplement. It's been shown to help with recovery from during the reperfusion phase after ischemia. Hydrogen water has been shown to be helpful, and there's several ways to get access to it. Hydrogen water is very interesting and very safe thing to experiment with. You can get tablets, you can get straws, you can get a bottle that makes it. Ion Bottle is the company. There may be a particular way to use red light therapy in that setting as well. So that's an approach that I'm taking. Plus, I think you have to deal with the circulation. You can't just deal with the way mitochondria are impacted by it. So treatments that improve circulation and break down microclots. I also use nattokinase. There are a lot of people that have benefited from it. I like vinpocetine, it's a natural product that comes from periwinkle that's been shown to improve blood flow in the brain after a stroke, blood flow to the lungs, and sometimes blood flow in the periphery. There are some drugs maybe we'll get to talk about later that might be used in that setting. Ginkgo biloba, as well as aspirin, also helpful for dealing with the clotting aspects, and pycnogenol, which is a flavonoid from French maritime pine that actually has been shown to improve blood vessel function in a wide range of conditions, including post-COVID.
All right. No, that was a great list. And just if you're just joining, we will be summarizing all of the treatments talked about in this webinar and making a list of them, so it's a little bit easier for everyone to read, especially if you have brain fog or any kind of issues with vision. All right. So let's go to Stuart, if you want to wrap us up for the ME/CFS round, and then we're going to go back through the loop again for MCAS and migraines next.
I think, Jen, you need to keep us on track, because everything that David says and then Leo says, I'm like, oh, I want to comment on that and blah, blah, blah. And I just could talk about this for hours. So I wanted to make a few points. When Leo, Dr. Galland, was talking about the Krebs cycle, I show this image to my patients every day. And I'm like, here's my image again. What does it do? Here's where things kind of come up. A few comments I just wanted to make right off the bat. I learned this in high school, I learned this in undergrad, I learned this in medical school, and then I become a doctor and I never think about the mitochondria again. So I think if there are any doctors in the room or clinicians in the room, that's important. Think about the most important little thing in your body that makes energy, and to familiarize yourself with it. The other thing is just this concept of a tool. And I'm an internist. And I tell my patients that because I'm not a naturopath by training, but I use a lot of supplements. I use a lot of herbal medicine. But there's very much that you have to meet your patient kind of in the middle ground, which is, what type of person are you? Are you, if I say, hey, go take pycnogenol, which by the way is published in a review article in Nature, Hannah Davis and a few other folks were on that paper, it's good medicine. It's also a prostaglandin inhibitor, I think, but that's good medicine. But culturally in medicine, we often think, oh, that I don't know what that is, so that's wrong, or I've never heard of that. So, listening to Leo just now, there are things in his list being, I like that. That's a great option. I've heard of that one. I've heard it in the forums, et cetera, et cetera. So I wanted to say that. I think, I guess I'm going to jump in the reperfusion injury. So what I tell my patients, so we have ample evidence that there was a microclotting disorder from this, at least initially in the initial phases of COVID in the early 2020s. And it will cause issues with oxygen getting into tissues. When we get that blood back in, it's not a free lunch. The cycles of the electron transport chain, they're making free radicals, and they cause this, cause damage. And things that have been helpful, so Leo, you kind of alluded to it, but some of the drugs, so empagliflozin or Jardiance is a drug. It is a diabetes drug. So when we think about the Krebs cycle and getting energy in, we're taking amino acids from proteins, fats from fats, fatty acids from fats, and glucose from carbs. And Jardiance is going to make you pee out glucose. So I kind of held off a little bit on using this drug, but I've actually used it independently for patients and have had some good benefit to it. And it might be working on the reperfusion injury. That was initially proposed by who I would call Team Clots, so the South Africans and the English that were working on the microvascular aspect of this illness. That's a good drug, Jardiance. There's a few other kind of drugs in that category, but it does make you pee out glucose, which is if your issue is PEM, maybe not, but you need to have that conversation. Saffron. So Leo, use saffron for sleep. Saffron can help with reperfusion. But then again, you need to kind of, you know, is saffron stronger? Is it more safe? Culturally, I think we need to have a bit of a shift on, you know, supplements as a medicine that can work in addition to these other pharmaceutical drugs. So
Yeah,
I wanted to jump on that.
trials on saffron. I mean,
Pardon
there
me?
are
Yeah.
randomized clinical trials on saffron for sleep
Mhm.
and mood.
Yeah, and why is that? Why was that not taught to me, or why is that not in the guideline for sleep and whatnot? You have to look, but I didn't have that time as a doctor with only 15 minutes with my patients, and so I think like really at the end of the day we need to have a bit of like a change to how we're thinking about this. But I'll stop there because Jen, I think you need to keep us on time.
Yep. So let's combine the last two categories because they do actually overlap decently. So the last two are mast cell activation syndrome, so MCAS, and also migraines. So people who get long COVID and then their primary presentation or a good chunk of their presentation is migraines and MCAS. So let's go back through the loop and we'll have David, what are your kind of go-tos for those folks?
Yeah. So I think that you know, as I mentioned, I think that for MCAS, you know, when we're working with MCAS patients, we're really trying to understand a few things. First is how are we stopping, you know, sort of free circulating histamine from causing problems. Then also how are we stopping mast cells from degranulating, you know, mast cells are these immune cells that trigger histamine release. How are we stopping those mast cells from activating themselves and triggering the release of histamine and other inflammatory cytokines? You know, our physicians at the core will manage MCAS with you know, a variety of different mast cell stabilizers. You know, so that range from, you know, herbal things like curcumin that, you know, Leo's already mentioned, all the way through to combinations of different histamine blockers, H1 and H2 blockers that can be helpful for the people who are experiencing mast cell activation syndrome. In addition to managing those symptoms, I think it's really also important to talk about hormonal dysregulation and MCAS and how those two things interplay, especially in people who menstruate, who are coming to our centers for care when estrogen levels are surging. This can be a real problem for both histamine release, mast cell degranulation, and histamine metabolism. So helping people through you know, helping people through hormonal cycling, especially hormones of ovulation, and helping them to manage histamine levels at that point through, again, various hormonal therapies. And I don't like talking about specific hormonal therapies or specific drugs because honestly, we tend to work with products like Mira, you know, where we get people to sort of like track their hormonal levels and work with endocrinologists to make recommendations based off of that, as opposed to, I think it's very dangerous to fall down the road with hormones to just be like one size fits all, you know, take some testosterone or take some progesterone or, you know, like that's not a good approach. But I think we should be aware of the fact that hormonal cycling can wreak havoc on histamine.
No, that's great. And I think I'm actually going to go a little bit out of order. So I just let's actually jump to Stuart, and then we'll wrap this up with Leo. And then what I'm going to do is the last topic is POTS for people who present with long COVID POTS. And what I'm going to do is I'm going to use this to move us into the next topic, which is sort of like, what's your next line? So if you've exhausted your kind of go-tos, let's do first and second line items for POTS when we do that one next. But for now, let's continue the loop through MCAS and migraine presentation.
Gotcha. I think a few things. One, where's the MCAS coming from? Like, is there something that you've acquired that the mast cell is degranulating? it's a lot of trial and error of meds, unfortunately, but your H1 blockers, cetirizine, Claritin, Allegra, Ketotifen is used to be available over the counter. It can be compounded, it can make you a little sleepy, but that's a good one. Pepsid. Montelukast is a mast cell stabilizer. There's actually some published data, I think, on luteolin, which is again is a supplement. Combining it into PEA luteolin is called Miraca. Using DAO enzyme with meals has been helpful. I've liked a drug called Amlexinox. It's a drug that's used in Japan for mouth ulcers. You can get that compounded as well. It causes a little bit of weight loss. Again, I've had people with weight gain and weight loss in long COVID, and everyone's very different, but that's an option. Statins are something that I want to bring up, which I've always thought help the vasculature or interacting with fractalkine, and there's evidence of elevated fractalkine levels in long COVID, but it also might help with the mast cells in the endothelium. There's really a lot. Prickly pear, I joke with my patients, I never thought I'd be a doctor being like, go get your prickly pear, and there's a lot out there. And so Mast Cell 360 is a great website to kind of like coach people through low histamine diets and potential other kind of supplements. Perilla seed extract is another one, but it's really like people who are having these reactions, they are degranulating, the mast cells are doing damage, get on some meds as we try to figure out what's actually going on. And sometimes this is unfortunately lifelong therapy.
All right, and then Leo, let's jump to you.
Okay. Yeah, well, what leads me to suspect mast cell activation in a patient, certainly migraine involves mast cells. It also involves impaired mitochondrial function, so that migraine phenomena, most of the patients that I see with long COVID in whom I suspect migraines don't actually have headache as the most prominent feature. They may have dizziness or some other symptom. One of the characteristics of migraines is it's episodic. It can involve the GI tract. It may be a brainstem migraine, which is primarily involving changes in autonomic function. The alternative treatments for migraine, I mean, the headache part responds the best to drugs. And I've even seen patients in whom PEM was a migraine manifestation and responded to migraine treatment. Not very common, but you need to be aware of it. And those drugs, of course, have to be prescribed. But the natural products that work for migraine, coenzyme Q10 at a high dose, 400 milligrams a day, riboflavin, 100 to 400 milligrams a day, has been shown to be helpful, and magnesium. Magnesium also can help with sleep. Dose of magnesium needed is about 300 milligrams a day for an effect on migraine. For mast cells, the natural product that's been studied the most is quercetin. You need a pretty high dose. You might need as much as 1,500 to 2,000 milligrams a day to really see a response. Quercetin plus luteolin works well together. Pycnogenol has some mast cell stabilizing effects as well. The dose there is probably 100 to 200 milligrams a day. But these are all things you have to, if you have a mast cell problem, the very drug or supplement that you most need might also make you sick. I mean, that is the problem with it. It is really a devil. And so I start to suspect it if somebody has a lot of adverse reactions to treatments that should be helping them. If they seem to have wild fluctuations in symptoms and be triggered by a lot of different things, whether it's temperature, light, physical activity and movement, there's a certain unpredictability to it. Electromagnetic fields. I mean, this starts to sound crazy, but it really isn't. Mast cells are sensitive to electromagnetic fields. There's a study done at the Karolinska Institute. I mean, that's the place that gives out the Nobel Prize, so it's not a low-grade place. They found that sitting for 2 hours in front of a TV monitor caused changes in the mast cells of about 20% of the people who were doing it. So it's the erratic, crazy, chaotic nature of mast cell activation that leads me to it. A lot of people with POTS have mast cell activation, and there's a definite link there. Certainly, it's worth a trial of the antihistamines that Stuart mentioned. If you show a response to antihistamines, maybe there's a mast cell component, and that needs to be pursued further.
Great. And Leo, you kind of mentioned POTS there towards the end. So I think this will be a great segue into, okay, so what are the kind of your first line go-tos, and then what's sort of your next line go-tos for the folks who present with a primarily POTS heavy presentation of long COVID?
Okay, so the first question is, does this person have POTS? And I have them do a 10-minute lean test, and I refer them to the Bateman website, where they actually demonstrate it. And I have a description I give my patients. It's really important, I think, to check blood pressure as well as pulse, because I see a percentage of patients with this condition who actually have a drop in blood pressure. And that's not POTS. That's neurally mediated hypotension or orthostatic hypotension. The initial approaches are the same, but they may not be, but they may start to diverge because they're different mechanisms. So I do ask people to do that, and I ask them what their symptoms are when they're standing. And generally, if you have POTS, there's going to be dizziness, maybe shortness of breath, weakness. When you're standing, you may feel your heart racing. You may not feel it, so you need to check it. The first line treatment for POTS and orthostatic hypotension is adequate hydration and adequate salt. And sometimes you really need a lot, and it makes a difference. And there are a variety of electrolyte drinks that you can use. Sometimes the use of support hose is helpful. There's some very good online resources for that. If you have difficulty exercising, standing or walking, try exercising lying down using resistance bands. Now, of course, you have to, if the problem is PEM, lying down may not be much easier for you than standing. But if it's primarily POTS, then you may be able to maintain your conditioning with supine exercise rather than the usual way that people exercise. Drugs that can work. The standard drug treatment, beta blockers are probably the first line drug for the long COVID POTS, because POTS is divided into at least 3 different mechanisms. There's an excess activity of the sympathetic nervous system, that's hyperadrenergic POTS. That is what most people who either have mast cell activation or long COVID have as the mechanism of POTS. There's increased discharge of sympathetic nervous system fibers from the brain, fueling the rapid heart rate. And controlling the heart rate can really make a huge difference. And beta blockers can do that effectively. However, if you also happen to have mast cell activation, and certainly if you have a history of asthma or anaphylaxis or severe allergies, beta blockers are probably contraindicated. So there is a second line drug called ivabradine or Corlinor, which controls heart rate. It's basically not approved for this purpose. It's expensive. It can be hard to get that controlled. There are certain things that have been demonstrated to help control the heart rate of people with POTS that are natural. They're a little effective, definitely worth exploring, have been studied in a controlled fashion. Vitamin B1, thiamine at a dose of 100 to 200 milligrams a day. Melatonin. Melatonin also can help to stabilize mast cells and may help with sleep. Gluten-free diet was shown to help people with POTS control their heart rate, even if they didn't have celiac disease. And I'm not quite sure what the mechanism was there. On the other hand, if you're not doing well with these approaches, you may have the second type of POTS, which is called vasoplegic or neuropathic. And in that condition, and that's harder to deal with, the blood vessels, the veins especially deep in your body, dilate. And it's as if you are getting dehydrated internally. You're not really dehydrated in terms of your whole body, but you're losing blood into these dilated blood vessels. Mitodrine might be helpful for that. And I haven't come up with a third line drug in that for that category as yet.
Okay, that was a really great overview. Thank you, Leo. I'm going to jump to David next.
Yeah, so I mean, I think Leo's done a good job with medical management there. And I think I want to amplify one of the challenges that we have here, which is, as Leo mentioned, most of these things are off-label for POTS. Most of the things mentioned are not on label, which means that it's hard to get the drugs prescribed. It's hard to pay for the drugs because they're expensive. So the only other thing that I'll add is, you know, where possible, using compounding pharmacies, we use the heck out of cost-plus drugs and places like that, where people can get off-label prescriptions filled quite cheaply. Can be really, really helpful. But also just naming the fact that we need good quality trials in POTS patients to justify the use of these things. And when I say good quality trials, I mean not just saying anyone who meets diagnostic criteria for POTS or dysautonomia gets ivabradine. You know, like, that's a terrible approach. That is an approach that guarantees that you'll have a failed clinical trial. Not naming names on any federal agencies here, but, you know, that's not how you want to do it. And being a little bit more judicious with the way that you design clinical trials, indicating that you actually understand the mechanisms behind dysautonomia and POTS that lead to these issues. So that's medicine. You know, in terms of other interventions, you know, I will point out that I think that breathwork is still something that is really, really helpful for folks with dysautonomia and POTS. As Leo mentioned, the reason for the POTS is, you know, just overactivity of the sympathetic nervous system. And there is really good quality evidence across multiple fields showing that specific breathwork protocols, you know, primarily protocols that focus on parasympathetic breathing, can downregulate sympathetic nervous system activity, upregulate parasympathetic nervous system activity, your rest and digest, and give you relief in the moment. The only thing there that I want to point out is that breathwork is not neutral, and it's not easy. You know, like, we're not asking you to do nothing when we're asking you to do breathwork. So you can make the mistake of sort of just prescribing breathwork and thinking, well, this can't harm anybody. But for those who are quite severe, parasympathetic breathing can be hard. It can be challenging. And sometimes you need to work up to it. So it's not just jumping into sort of like a Wim Hof training protocol and that you saw on YouTube and breaking yourself, because that's what will happen. Building up slowly is really, really important there. To that end, you know, cold therapies are also evidence-based for assisting with these sorts of things. So other modalities outside of medications that can downregulate sympathetic nervous system activity, cold therapy can be very helpful. Again, this is something that you want to, you know, be very careful around just jumping straight into, because it can be stressful on your physiology. But it's one to look out for. And by contrast, one of the biggest triggers for our POTS patients can be a hot shower, and understanding that, and understanding, hey, you know, hot showers are over for you right now until we get the POTS under control, because heat increases heart rate, triggers sympathetic nervous system activity, causes worsening of symptoms. And so, so people just stepping into the shower in the morning can cause problems. The only other thing I'll say is, you know, we've produced a lot of free material that's on our YouTube channel and is available in other sources about autonomic rehabilitation, which I think is a really important driver in improvement in people's POTS and dysautonomia. And we can talk about experimental approaches to that as well in the next section, but don't sleep on autonomic rehab.
All right, and then Stuart, let's wrap up with you, and then we'll start going into some of the other presentations. We are running a bit short on time here if we want to have the Q&A be the full 15 minutes. So I think what we may do is jump into just like kind of what are the next line and just sort of combine that with sort of experimental and trial treatments that you're interested in seeing.
So I think Leo and I have a similar approach, which is there's a fundamental underlying reason for like why this is happening to you. You know, like it just didn't come out of nowhere. But sometimes when I struggle with my patients and I'm trying to like figure out what's going on and handling the mast cell or whatever, I do, Leo, I think you're mentioning some of the migraine medicines do have some, you know, ill effects. I did want to briefly mention them. So something like a CGRP antagonist, just so people in the audience can hear the names like Aimovig, Ajovy, Emgality. I've had people get on them and have had help. So trying to get back to the migraine, I just wanted to mention that those drugs work on mast cells. Like you can look in the really good literature, that's like where they work. I've had people have good effect, but logistically, you oftentimes have to see a neurologist or a migraine specialist. The number of times that I've tried to prescribe this drug and then insurance said no is pretty high. Going back to POTS, you know, rounding it out, protostigmine can be helpful. It's a myasthenia gravis drug. Just putting it back in your mind, there was a publication out of one of the Harvard hospitals a couple of years ago, increasing extraction of oxygen, increasing the capacitance of blood into the lungs. I've had some good effect on that. I'll kind of leave it at that so we have more time for other things.
All right. And so I think what I may do is, because we're running a bit behind, I'm going to shrink the Q&A section down to maybe about like 10, 12 minutes. And so we can have a little more time to talk about what are kind of like your maybe more like emerging therapies for some of these conditions, and what are some of the experimental ones that you're really interested in, that may be either in trials or maybe they're available in other countries, or some of them are maybe even available here, but it's just they're not things that have a ton of evidence behind them, but they're exciting or you've seen some early promise. So I guess, Stuart, do you want to start this one off?
Sure. Sorry, I was muted. So, I mean, David's doing the trial right now. Truvada has been helpful for people. So Truvada is a drug that we use in PrEP and in the treatment of HIV. It has some effect on CMV and I think Epstein-Barr virus. I've had people who, I'm going to talk really quick so we get a lot out of here. I've seen it have benefit in people. It's been a good drug. I talk about risk versus benefit as a person who's given blood thinners to people before. We use this in hundreds of thousands of people for HIV PrEP. It's a very safe drug. You need to check your kidney and urine tests just to make sure your kidneys are doing okay. That's been a great one. Ravirac has been a good drug for me in combination with statins. Ravirac is a CCR5 receptor antagonist. David, you're doing this trial again as well. I'm not sure if you're going to find benefit to it, but it has been a good drug, and I think kind of seeing if that is a good an option. So that's something. Other antivirals, there's stuff on the market, just in terms of like supplements. Talks about sofosbuvir, out of UCSD in vitro. That's something that's on my mind, but you know, very expensive drug. Some of the blood thinners, so Jardiance, I used in combination with the triple therapy. Triple therapy, in my opinion, I think was really effective early on from the early stages of long COVID when we clotted off and we were having microclotting effects. The majority of my patients would say that they got around a 10 to 15% of benefit, but it has actually been curative in a handful of people. Something like Solodexide, there was a study out of Tunisia that's not available in America. It seems to help the endothelium. Other things that help the endothelium, well, phosphatidylcholine is a component of that. Something called plasmalogens. These are things that are in the inner lining of vasculature, mitochondria, like everything. I've heard of some people just having really great benefit with plasmalogens, but they're expensive. Vasipa, there's a small trial of case reports of Vasipa. So Vasipa is icosapentol ethyl. It's an omega-3, so there's different types of omega-3 fatty acids. This is a very highly purified version of EPA. There's trials out, you know, I want to look at the gut on everyone, so that's important. There's a paper out of Japan recently about minocycline. Minocycline is kind of similar to doxycycline. Showed good benefit in this small trial. I don't know why it's working. It could be an IDO inhibitor. I'll stop there. I'm kind of talking very quick, but I just want to make sure people in the audience hear about certain drugs that are out there.
All right. And then David, I'll jump to you next.
Yeah, I mean, I could go on forever about the things that we're interested in, but I would, you know, I would say, let's talk conceptually. You know, the first thing I would say is like long COVID, ME/CFS, other infection-associated complex illnesses do not happen in a vacuum. And so if we step away from our clinical trials for just 1 minute, one thing that I would tell you about what we're seeing in our research studies, these are the studies where we're trying to understand the pathophysiology, like what's happening to the physiology of people with these conditions, is that we're seeing, you know, it's very individualized. So depending on your infection history, depending on your past medical history, everything that Stuart and Leo have been saying, you know, whole session, you know, let's stick with long COVID for a minute. SARS-CoV-2 has this ability to wear down your immune system and dial up some of the old villains that were hanging out. So CMV, EBV, other herpes viruses, other parasites, other viruses, and then other bacteria, tick and vector-borne things like Bartonella, Babesia, Borrelia. So a lot of our studies, which we hopefully will be publishing this year, really show this. We're going to see really stark results on how some people, after getting COVID, so that COVID was the clear trigger of their symptoms. They were perfectly healthy beforehand, but now they're testing positive for these other pathogens. So my dream, you know, if you said, what does long COVID or complex chronic illness look like? You walk into some sort of futuristic scanner and it tells you these are the pathogens that are reactivating in your body, causing problems. These are the ones, and you know, this is a futuristic dream, but it's not so far off with things like spatial transcriptomics, where we can tell not just is the pathogen there, but is it interacting with tissue and is it causing problems? Because, you know, the sort of you know, the sort of intuition that we need to ignore is that just because your symptoms started with COVID, maybe it's the COVID causing the problem. It could be many other things that were sort of cascaded and triggered down by that. So the need for, if we're dealing with persistent pathogens, the need for personalized approaches, which we can achieve through things like adaptive platform trials, which allow us to sort of determine which arm of a study you go into based on your blood testing. That's the sort of clinical trial I want to see, as opposed to, you know, a monotherapeutic. I also want to start to see combination therapies, you know, brilliant study on famotidine, you know, showing that that can improve cognition in people with long COVID. There's a similarly good study showing that, you know, hyperbaric oxygen therapy can improve cognitive impairment. Other studies with red light therapy showing cognitive impairment improvement. Do those benefits multiplex when we combine them all together, or do you hit a ceiling? You know, like these are questions that are worth answering with tools that we already know seem to work in a vast majority of people. And I really wish that we could get some of these combination trials going, you know, very, very quickly. And then when we're talking about pathogens reactivating and all that sort of thing, and we think about why, and we think about the ability of long COVID ME/CFS to cause immune dysregulation, immunomodulators become important. So a shout out for our rapamycin study that is starting, our low dose rapamycin study. Again, I'm just so excited to not just understand how it does on a population of people with long COVID, but really dig into the responder analysis. Who responded and why? This is what we're doing with our lumbrokinase study as well. You know, we're getting, you know, we've received some critique online about lumbrokinase in a clinical trial because they're like, oh, well, the population already knows that that doesn't really work. And that's not true. The population, you know, as Stuart said, the population knows that like some people get a big boost from it, some people get a smaller boost from it, you know, but people do get a boost from it. And what we're seeing in this study, because it's open label, is we're seeing people's fibrin levels dropping as they're taking the lumbrokinase. We can study that really closely and we can see that it's working. And then what we can actually do is understand like what is the baseline level of fibrin levels where lumbrokinase actually starts to produce symptom improvement as your fibrin drops down. And that study has never been done before. That is the most important thing when we're trying to develop guidelines for who gets what, understanding what existing test we can use to good effect to then produce movement on symptom scores. So that's the sort of clinical trial design I would like to see overtake everybody with long COVID gets one drug. And, you know, and then because it's such a multi pathology disease, no one gets better, or the statistics say that no one gets better and we're back to square one.
I think I completely agree with you. I think with these kinds of conditions, it's just like a lot of times, I mean, you're going to look at this and it's like the approach we have to take kind of with like HIV, right? You have to hit it from multiple angles at the same time. So it's like doing these monotherapies and having a very heterogeneous group of people, you know, yeah, you're only going to have a certain subset that benefit, and they're going to say that's not statistically significant and that the trial quote unquote failed. But that's actually not true. It works for a subset. So I completely agree with you wholeheartedly. And yes, thank you for saying that. All right, so let's see. I'm going to jump to Leo. Do you want to wrap us up with the last things, then we'll jump into some audience questions?
Yeah, sure. Yeah, the areas that I think that the question of viral persistence and reactivation is one that really needs to be looked at, and maybe the source of unique therapies. I don't know how many patients you've treated with Truvada, Stuart, but I think that's that as an antiviral is really worthwhile. The role of the gut microbiome in impacting immune responses and also serving as a reservoir for virus needs to be explored. And there's this center in Milan that has a protocol. Their research has indicated that the virus is able to function not only as a mammalian virus, but as a bacterial virus, a bacteriophage. And they've, with using electron microscopy, shown it inside normal gut bacteria. They've used antibiotics. Maybe that's where the minocycline comes in. Their present regimen is to use rifaximin, which is way overpriced in this country, way cheaper in Italy, along with some probiotics. And the type of probiotics they're using are primarily a Bacillus subtilis, a soil-derived organism. And they claim to be seeing good results with that, but you have to do it multiple courses. So the question is, so those are the areas that I'm interested in moving into in terms of looking for answers.
Okay, great. Thank you guys so much. And I'm going to jump into, we have some audience questions. So I'm going to go through the ones that are primarily kind of around treatment, since that's the focus of this webinar. So the first one is, any thoughts on nicotine for long COVID patients? Just jump in.
Do you want to address that, David?
No, you go, Leo. You go.
Okay,
I know that you have good thoughts on this.
Okay, well, look, the theory of why nicotine works is that the virus can bind to the receptor for that nicotine also binds to on nerve endings, that nicotine binds more strongly and it can displace the virus from the nerves. And that's an interesting theory that has yet to be proved. You see a lot of stuff online about nicotine. I haven't seen anybody yet who got cured with nicotine. Nicotine is a stimulant, so it's possible that your energy or cognitive function might improve when you take it. The theory that what you're doing is displacing the virus from nicotine receptors doesn't really explain all of the different benefits that people describe from using a nicotine patch. So I'm skeptical. I think that needs to be, I think there may be some people who will benefit, and I would primarily look at it in people with cognitive dysfunction.
Okay. And the next question I have is thoughts on JAK-STAT inhibitors. So I don't know if David, do you want to jump in at that one?
Sure. Yeah, I'm more than happy to take that one on. You know, as we were discussing, I think that there's more than one way to sort of slice the population of people with infection-associated chronic illness, and we've certainly read case series and case studies of people experiencing extraordinary improvement from JAK-STAT inhibitors. I think that there's reasonable rationale for why that might happen, from everything from, you know, autoimmunity and chronic inflammation all the way through to brainstem regulation of sickness behavior, which we saw in a Nature paper. You know, that can be triggered by viral infection and just not switched back off. And so, you know, you've just got this sort of systemic inflammation problem occurring. My concern right now around JAK-STAT inhibitors, which is why our team is currently not running any trials on them, is we don't have good ways of ruling out people who absolutely have viral persistence right now, you know, and JAK-STAT inhibitors are effectively immunosuppressive drugs. And so I worry that without that very clear way of identifying who is having a persisting pathogen in their system and who isn't, or many persisting pathogens, you could very well make a situation worse.
I wanted to piggyback just on that one real quick. I remember when this was coming out, and you know, patients are desperate. We're trying to get these drugs. They're expensive. It's hard to get an off-label drug like that. But that has been my biggest concern. But one thing that really hit my brain is, you know, it's like, well, there's an underlying pathology. There's something there. There's some bug that we don't know, or it's COVID or whatever. Is that a good idea? But I really wanted to underline what you said, David, which is sometimes that switch won't turn off. And that was something, when I read that paper, I was like, oh, okay. So, you know, using the spear assay to see if there's spike floating around and all of your, you know, your really good assays, like that's how I would really select that patient population. And not, if the trial, I think Wes Ely's doing it at Vanderbilt, to not throw it out if it's negative, but as an option for people. I did want to comment on nicotine real quick. I've seen it to be beneficial. I just had a patient this week who had a terrible crash from it. There's a theory, again, the paper came out of Leipzig, University of Leipzig in Germany a few weeks ago, about using a special tracer, and it seems to kind of back up the theory of how it's blocking that receptor, but I would admit that I don't know all of the biology behind it. One of the theories is that it liberates spike, and the spike goes out and causes further damage. So there's kind of these like people will combine it, but it's something that I've seen work. But just please be careful if you're doing this. I know long COVID patients are desperate, especially when they can't get anyone to help them, but start low. If in general to a human being is what I would say.
Yeah, and also just, you know, if you've got cardiovascular disease or history of it or risk factors for it, you definitely always want to talk to your clinician first, because, you know, nicotine can be a stimulant and that can put extra stress on the heart. So, all right. So another question from the audience was, oops, sorry, I muted myself. Thoughts on peptides and GLP-1s.
Can I jump on that real quick? Yeah.
Sure, go for it.
GLP-1s, I've seen it work clinically. So GLP-1s, so everyone, what is a peptide? So a peptide, a string of amino acids comes together as this 3D structure called a protein. Protein make things work, okay? A peptide is just a small string of amino acids. The most famous ones on planet Earth right now are the billion-dollar drugs, the GLP-1s. GLP-1s have helped my patients. In the trials, it does show a reduction in mast cell or allergic issues. I'm seeing some benefit. My counseling would be, if you have obesity, it's easy to get, but then it's kind of hard to get this covered if you don't. A lot of long COVID patients have no weight to lose, but I have seen it work. Jumping to peptides, this is a controversial thing. I can't always prescribe peptides, but I live this with my patients. There's a lot out there. There's a dysautonomia paper that came out as a preprint from Patel and Wynn at WashU and Stanford using AR. We don't even know what peptide it was. I've seen people get benefits with peptides. But I think culturally in medicine, there's certain things that we don't know where the FDA regulation is, and patients have had to go off and do their own thing. There are just reports that I hear on the internet. I tell my patients the history of long COVID was written by patients. Things like MOTS-C has been helpful for leg pain. TB4 fragment, there's a whole bunch of them. They seem to be safe, but I would really try to find a clinician who has experience in that. But those are some ones. I did see a question about thymosin alpha-1 that seems to boost the immune system. That's an option for people.
The thymosin beta-4, I found to be really helpful for people with head trauma. Even years after the event. And I'm not sure what the mechanism is. It's been shown in laboratory studies to be really helpful with acute head trauma, and quite safe and available in an oral form, the TB4 frags.
All right, and then there's another one here. What about stellate ganglion blocks?
Yeah, I can probably touch on that one. This is an area that we're interested in, and we're hoping to run a clinical trial on shortly. The TLDR of it all is, in the majority of patients, it appears to give a small boost that is short-lived. But there are people who have tremendously benefited from it, and one of one of the people who has been quite vocal about that is an individual online, Diana Cowan, who was bedbound and attributes a significant recovery to stellate ganglion block work with stellate ganglion blocks, and we're looking into the literature with her collaboratively to try and understand if there's something different about the protocol that she received, which was quite different from what is standard for a stellate ganglion block. It involves more dosage of the intervention and over a shorter period of time. So this is something that I think is always worth exploring when you see a few people standing up and saying, hey, this moved the needle, especially when we're hearing from very severe patients, because we have so few options for very severe patients that we're going to jump on that and see what we can do to understand it better.
I'm going to jump on that, if that's okay. I'd like to very severe. It's so hard as a clinician. We make decisions with our patients of like, hey, go spend the money and do this and travel and get this done. Plugging Luke Liu, who has been publishing the papers on this recent trial in 10 patients, 7 showing benefit. I don't know if it's throwing out a vagal, like some sort of dorsal vagal mode, or like what's going on, or if it's the nervous system does everything, and we're really just at such a small understanding of like how it's mediating this. I've seen it help people. I've seen it not do things in people. My only recommendations for patients would be go to someone that has some reputable kind of like backing, and it can be hit or miss. And this is unfortunately the part of the long COVID life that my patients live through, which is Sometimes it works, sometimes it doesn't. If anyone from the government or from insurance companies is watching, like, man, it would be great to be able to get some sort of coverage for this because it is a big financial decision for people.
Yep. And I just want to call, we are at time. I don't know if, panelists, if you guys have to leave, by all means, if you want to stay and kind of answer a few more questions, we can absolutely do that. So I just want to ask, if anyone has to drop off right now, let me know if you guys are up for staying for a few more minutes. I've got a few more questions.
4:15 ending is so irregular. I can stick around a few more minutes.
Yeah,
So-
Okay.
a few.
Okay, thank you guys. You guys are great. All right. So another question that came through was thoughts on EBOO. So this is a type of ozone therapy that kind of acts like dialysis, like you pull the blood out, filter it through with some ozone and put it back in.
I would say in general, we're seeing a lot of difficulty with a few things. Where in people with long COVID, where we're seeing gas exchange issues, not just not enough O2 getting to tissue. We're also seeing hypocapnia, so not enough carbon dioxide in the system. And so, there are people who are talking about lots of different interventions. We've spoken a little bit about supplemental oxygen. We've spoken a little bit about home, oxygen compressors. We've spoken a little bit about, even handheld oxygen therapies. And, EBOO is another one of these things that may also be helpful. And I think what we need to try and understand is, and I think we need clinical trials to try and understand when each intervention is warranted, and something like EBOO, I think, could be warranted when you're not just having perfusion issues, but you're also having issues with efficient oxygen carriage, within the bloodstream. So, which also leads into issues with iron deficiency and hemoglobin issues and so on and so forth. But I do think that, these things deserve a detailed exploration, because the gas exchange problem is real. The tissue perfusion problem is real. And then all of these interventions get at them from different angles. So the real question becomes, when and how often and for how long are these interventions useful?
I just want to say, you mentioned hypocapnia, David. Low carbon dioxide is not good for blood flow to the brain. When you get hypercapnia, which you can get from hyperventilation, among other things, or interventions that reduce carbon dioxide in the blood, you actually get constriction of blood vessels in the brain. So that's a concern that I would have. The other thing about ozone therapy is ozone can be very rough on blood vessels. So depending on the concentration where that ozone is being injected back into the vein, there's some risk of aggravating the endothelial inflammation.
All right, great, thank you. And then,
would you mind if I
sorry.
jump on this real quick, which is just, so David published this, a joke now, years ago about the end tidal CO2, and that it's a mitochondrial issue. And to really what Leo was saying, so the cerebral arteries are vasoconstricted. There's a company, I have no vested interest in them, it's called Lumia, to try to detect blood flow. They're doing trials. People can sign up to see about getting a device there. I have used something called the CO2 rebreather mask, where you are physically trying to get more CO2 in you. It has been really helpful for brain fog in some people. Again, life as a long COVID patient and a long COVID doctor, I have seen people have crashes from it as well. So that's something, this is Angela Chung's work. She's going to be publishing this eventually, using a CO2 rebreather 30 minutes twice a day for a month to get the CO2 replenished to get that blood flow to the brain. So that's something that I'm very excited about.
Oh, that's great. Okay, and then one more here is apheresis. So apheresis is kind of a general term. So there's like plasmapheresis, there's help apheresis, and then even like in Europe, there's immune absorption. So there's different kinds. So I guess I'll just kind of put it generally out there, and anyone who wants to comment on it.
I could probably start, and I'll keep my comments brief on this, but you know, I think that if everything that we've been talking about with regard to blood clots and autoantibodies and inflammatory cytokines and all of these things that are circling through people's blood and tissue, you know, is ongoing in a person with an infection-associated chronic illness, apheresis, and other sort of blood filtration interventions can potentially address that. But the problem is, unless you're addressing the underlying cause, those toxins and cytokines and pathogens and you know, and sort of just things that are causing symptoms are going to return relatively quickly. When we way back in 2021, we reviewed some of the data out of a help apheresis clinic in Germany, and that was precisely what we saw. We saw microclots and hyperactivated platelets going away and then returning within 48 to 72 hours in the vast majority of patients who were experiencing the interventions. So these are not cheap or easy interventions to go through. They can be quite exerting, and they can be quite, you know, a little bit dangerous because you're using large gauge needles, and there's an infection risk, and so they should be used carefully. You know, again, with this understanding of like, you know, am I just going to do this and in 72 hours I'll be feeling the same, or have I done something to address underlying causes that means that once I go through a procedure like this, there's a chance I might feel better for a more prolonged period. As with everything, we need more research.
Does either Leo or Stuart, did you have any commentary on apheresis? Or I have like one more question, actually two more.
Well, you can go with those. Let's go.
Okay. So one other question is about monoclonal antibodies, and I suspect that this is in reference to those against targeting spike protein. In terms of
great idea. Wish we could investigate it. Great idea. We should investigate it. On our side, on the research side, all I'll say is we need drug company participation to investigate, and we're not getting that easily. So, like, you know, that's what we wish for.
And also the which generation virus does the person have? Because there's a lot of mutation, and monoclonal antibodies are very specific.
All right, and then the last one here is fecal microbiome transplants, so FMTs.
Okay, interesting idea. The question is, who's the donor? Number one question with a fecal transplant is who's the donor? The donor is critical. The second question is what's the prep? Because just because you try to put a microbiome into someone doesn't mean that the niche is open. So I think there are a lot of unanswered questions, and I've seen strange reactions to microbiome, to fecal transplants over the years. Sometimes they've been really great in patient with MS, really well controlled. Another patient, but I've seen other people get worse or develop new diseases. One patient, you cure one thing and then they develop a form of psoriatic arthritis that they never had before. Who is the donor? You know, who is the donor, and what the interactions between the microbiome and your body are as complex as quantum physics meets rocket science. And we are there's so much about this area. We need to really be it needs to be very carefully targeted. I don't view this as a good shotgun therapy.
All right. And so I think that brings us to 1:30. So 1:30 Pacific. And so thank you guys so much. This has been so much information, wonderful discussion here. This has been really, really great. So thank all of you for joining us. Again, we're going to get the recording posted on our YouTube channel. And obviously you guys can share it wherever you wish. And also we'll be working on getting a list of the treatments that were discussed in here, kind of put into like a little bit more of an organized format that people can just review after. So again, thank you to our wonderful panelists. Thank you to all of the people who attended. And thanks to the team who helped set all of this up. And with that, everyone have a wonderful rest of your evening and a great rest of your week.
Thank you, everyone.